This is going to be Chapter 5, the Integument System, Part 1. And first thing we're going to do here is an introduction. The integument system is the most visible organ system in the body. Interruptions in the skin can pretty much provide a pathway for infectious disease, and it consists of the skin, hair, nails, and various glands. Structure and function. Integument system is an organ system that protects the body from damage comprising the skin and its appendages. Cutaneous membrane is another word for skin. Epidermis is the outer layer of skin. The dermis is the layer of skin between the epidermis and the subcutaneous tissues. And then we have accessory structures, which include hair, nails, and a variety of exocrine glands. 5 major functions of the integument. First of all, it protects. It protects the body from, or the underlying structures that are in the body, like the organ systems, from varying attacking bacteria. Temperature maintenance. Skin maintains normal body temperature by regulating the heat exchange. Synthesis and storage of nutrients. It synthesizes vitamin D, a steroid building block for a hormone that aids in calcium uptake. Sensory reception. Receptors detect pressure, touch, pain, and temperature stimuli that relate to the nervous system. So obviously you have nerve endings in your skin, and these nerve endings, as you touch things and feel them, you can feel the pressure, the temperature, if it actually caused pain, and so on. Excretion and secretion. Integument glands excrete salts, waters, organic waste, and breast milk. And this is kind of an overview. If you'll look up over here, this is the epidermis. This would be the dermis, or the middle layer. And then you have subcutaneous or hypodermis layers. Now, all of this area here is going to be fat. We're going to see hairs. The hair shaft. It's right over here. This area here is a sweat gland. We have ample blood supply underneath, but if you'll notice, if you'll look into this structure here, it's only capillary, very small vessels in this area, and our actual external skin, which is here, doesn't have any blood supply to it whatsoever. In the epidermis, we have 2 types of skin. We have thick skin and thin skin. The thick skin is found on the palms, hands, and feet. Thin skin covers the rest of the body. So the inside of your arm would be considered thin skin. The palms of your hands and feet would be considered where the thick skin would be. These are Langerler lines or cleavage lines, and these are tension lines that are in the skin. And if you'll notice, most of the people, whenever you look at wrinkles, will occur in these areas. Kind of shown better whenever we take a look at the face. These are most of the time where people get wrinkles at, which are in here, the fur on top of the head, around the nose, and around the lips. Here's another look at the epidermis layers. Stratum corneum, which we're going to talk about this. Stratum lucidium, stratum granulosum, stratum spinosum, and then stratum basal. And this again is a structure. This is the one that's actually in your book. You can find it, figure 5.4. Surface of the skin is at the very top. And then we have the stratum corneum, which is underneath it. This area here to this here. Then we have the stratus lucidum, and then the stratus granulosum, which would be this area here. Basement membrane that would attach the outer surface of the skin to the underlying tissues. And then we actually, underneath this, have the dermis. This would be the epidermis, and this would be the surface of the skin. Clinical note, dermatology. These are good clinical notes that are throughout the book. They tell about different variations of pathology or disease Dermatology is study and treatment of disease of the skin, hair, and nails. Plastic surgery, there are pretty much two reasons to do plastic surgery. One of them is reconstruction. If you broke your face horribly and needed it surgically reconstructed, and the other one is for cosmetic reasons. Layers of the epidermis. The outer layer there, stratum germinativum, is the deepest epidermal layer. It has epidermal ridges. It has germinative cells, and it has melanocytes. Epidermal ridges, stratum germinativum forms epidermal ridges. Germinativum cells, and these are pretty much large skin cells. They're germinative, or they germinate, if you will, where new cells can begin to grow. Melanocytes, they synthesize melanin, yellow-brown pigment that colors the skin. After that, you have the intermediate strata, 3 layers, progressively displaced from basal layer and become more specialized. You have the stratum spinosum, spiny layer that continue to divide and add thickness to the epithelium. You have the stratum granulosum. Granular layer consists of cells from the stratum spinosum stop dividing and make large amounts of protein. And one of the proteins that they make is called keratin, which is durable water-resistant protein. And then we have the stratum corneum, superficial layer of the epidermis, 15 to 30 layers thick, of pretty much dead epithelia. And this area is kind of keratinized or cornified, dead skin cells that remain connected by a desmosome and shed in layers. Another clinical note, that we can administer a lot of medications through the skin. The way that we administer those is they have to be fat soluble so that they will cross across the phospholipid bilayer. Transdermal administration is done in several ways. Nicotine patches is an example of this. Pain patches is another example of this. It must be lipid soluble. Another medicine that we can use is called nitroglycerin. Nitroglycerin paste, essentially, we put it on in inches. So in your clinicals, you might actually see somebody saying, hey, can you go give the guy in room 2 a half of an inch of nitro paste? 1.11, skin color. Pigmentation contains various amounts of 2 pigments called, which are keratin and melanin. Keratin is an orange-yellow pigment and normally accumulates in epidermal cells. And melanin is a brown, yellow, or black pigment produced by melanocytes. Next term on this list is going to be melanocytes. Manufacture and store melanin within intracellular vesicles. UV radiation. Small amount is beneficial, stimulates vitamin D in the epidermis. Too much can cause severe burns and damage. Melanin absorbs UV before it gets to the lower layers, and this is going to be important since we have blank cells down there, stem cells. We don't want them to be irradiated by any means. Dermal circulation, oxygenated bright red blood, reddish tint to the skin, and whenever we have somebody that's oxygenated, we even check capillary refill and consider them pink, warm, and dry. And then we have some variations on this, which is cyanosis, which is a blue coloration of the skin. And the reason some people get cyanotic is because you shut something called a precapillary sphincter whenever you're in shock. This constricts the actual peripheral vessels so that it will shunt blood towards the core. Vice versa of that, we have the other term called dilation, which means the lumen of the vessel actually becomes larger. And these are melanocytes. We can see them here. This is a cross section that's been brought down here. Melanocytes containing vesicles, melanin pigment, which would be for skin color. This is an actual melanocyte right here, and this is kind of attached to the basement membrane, or the membrane that would attach one layer to the next. Clinical notes upon skin color. An important indicator of bodily function. Examples of this are going to be paleness, which generally occurs in shock states, cyanosis, which generally occurs from hypoxia or low blood oxygen, jaundice. Jaundice is generally caused from liver failure. Let's go through these here. Bilirubin is a byproduct of protein metabolism. So if you get too much bilirubin, what happens is it will cause your skin to become kind of a yellow tint. This can occur first in the sclera of the eyes. They'll have a yellowish tint to their entire skin. So jaundice, yellowish. Cherry red skin. Last but not least, this is from cherry red skin is generally caused by carbon monoxide poisoning. The problem with carbon monoxide is that it likes the red blood cells a lot better than the oxygen does. So once it latches on there, it has a 200 times greater affinity, and once it locks on pretty good. So cherry red skin is generally associated with carbon monoxide poisoning. The epidermis and vitamin D3. When exposed to UV radiation, epidermal cells in the stratum spinosum and the stratum germinativum convert a cholesterol-related steroid into vitamin D3. This product is absorbed, modified, and released by the liver, and then converted by the kidneys into calcium, which assists the parathyroid glands in controlling calcium levels in the bones and in the vasculature. Skin cancer. Skin cancer is the most common form of cancer. Basal cell carcinoma. Most common skin cancer. Squamous cell carcinoma. Less common. Involves superficial layers of epidermis. And then we have melanomas. Usually begins as a mole and grows rapidly and metastasizes throughout the lymphatic system. Now, when something metastasizes, that means that it started in one location and all of a sudden it's all the way across the body in another completely different tissue. This is a very aggressive form of cancer and should be treated quite aggressively. If your cancer becomes metastatic or metastasizes, then easily you can have cancers pop up in other organ systems throughout the body. And these are different times. This right here is a basal cell carcinoma, and then this is a melanoma, which if you had a bunch of those on your skin, very easily you would go get that checked out. That just doesn't quite look right. Clinical note, skin lesions. We have primary lesions on the body, and the easiest way to look at those is by the figure 5.7 that's in the book. Primary skin lesions. So in the future, if someone tells you that you have a maculopapular rash, a macula is a flat spot, color varies from white to brown, and then a papule is an elevated firm spot that varies from brown to red or from pink to purplish red, diameter less than 1 centimeter. So if it has both of these characteristics, then it would be considered a maculopapular rash. What I'd like you to do is please look over these. There may be some test questions over them. The easiest way probably to do this is to look at figure 5.7. Each one of them will have something that's a little different, whether it be 1 centimeter, less than 1 centimeter, greater than 1 centimeter, or so on. You have secondary skin lesions as well, and this is another list. Examples: tumor, abnormal growth under the skin, more than 2 centimeters, pustule, elevated area, less than 1 centimeter, contains purulent pus, a cyst, something growing, liquid or viscous material, palpable just underneath the skin, a vesicle, containing serous fluid, a bulla, vesicle with a diameter more than 1 centimeter, and then telangiectasis, which is red thread-like lines on the surface of the skin. Fissure, also secondary lesions, which is pretty much just a groove that has eroded in the skin. I think we all know what a scar is. A keloid, however, is an over-exaggerated version of a scar. So it's kind of higher and thicker, a little bit more beefier looking scar. Ulcers, escoration, erosion. Please look at all of these. Ulcers, we may see in decubitus ulcers as an example of this, where pressure actually causes the tissue to become hypoxic. This causes necrosis of that tissue, and then the tissue to slough off. Once the tissue sloughs off, it leaves what's called an ulcer. We have scale, lichenification. Please again look over these, crust formation, and then atrophy of the actual skin. Vascular lesions. Good ones to remember here would be purpura and petechiae. You'll see these both, or you could see either of these or both of these in septicemia. Capillary hemangioma, big raised area that pretty much is embedded and infiltrated with tons and tons and tons of capillaries. Ecchymosis is just a bruise. The dermis has two major parts. It has a papillary layer and a reticular layer. Papillary layer is a dermal papillae, consists of loose connective tissue that supports and nourishes the epidermis. Reticular layer, interwoven meshwork of dense, irregular connective tissue. And then we have other dermal components, which are hair follicles, sweat glands, blood vessels, lymph vessels, and nerve fibers. Subcutaneous layer, and this is the layer that our fat is in. It's not a part of the integument. Loose connective tissue with adipose fat cells. Useful area for medication administration, and that's because we can inject something into the subcu layer, and in about 20 minutes, we get a full result from that drug. Medical skin conditions. Exanthems, herpes zoster, staphylococcal scalded skin syndrome, and then toxic epidermal necrolysis. An example of this last one would be Steven Johnson's. Take a look over these definitions and see which each one of them causes. Exanthems, acute generalized skin eruptions, can be caused by drugs, viruses, or certain bacteria. Herpes zoster, eruption of vesicles along a dermatome of a sensory nerve, and it's pretty much an adult form of chickenpox. Scalded skin syndrome. Syndrome is induced by epidermalic exotoxins A and B, which are released by Staph aureus. Causes detachment of the epidermal layer, so they'll just essentially slough off their skin. And last but not least, these are mostly allergic reactions, but Steven Johnson syndrome is a pretty nasty presentation, and the pictures will kind of give us 1,000 words on this. Viral exanthem is this figure here. It's figure 510 in your book. That's what those look like. Another version of viral exanthem, which is pretty much just reddening, super reddening of the guy's face. There's a varying list of drugs that can actually give you Steven Johnson's. Some of you are probably on these or have seen these before. Sulfacetamide, pheniotonin, those are for seizures. Azithromycin, nystatin, gout medication. Levaquin, which is an antibiotic. Diclofenac, Depo-dilantin. Alright, so all of these drugs can actually give us Steven Johnson syndrome, and this is what Steven Johnson's is. Kind of an autoimmune response of the body. It gives us a presentation similar to what scalded skin is. So this is treated whenever the patient presents with it like a burn. Accessory structures, hair and hair follicles. Hairs are non-living structures made of keratin. Hair follicles pretty much produce hairs. The structure of a hair follicle. Hair projects deep into the dermis and often extends into the underlying subcutaneous layers. A hair papillae peg of connective tissue that connects capillaries and nerves, hair root, portion that anchors the hair into the skin, hair shaft, part of it, the hair seen on the surface of the skin, cuticle, overlapping shingle-like layers of cells, and then a cortex, underlying layer of the hair, and then a medulla, which is essentially the core of the hair. And if you'll look here, this is figure 511 in the book, exposed end to shaft. We have the hair shaft here. We have a sebaceous gland over on the side. The hair root is in here. Connective tissue sheath of hair follicle. Blood supply to the hair. This is the hair cross section. Not very wide. Cuticle, cortex, medulla, wall of the hair, connective tissue sheath. Accessory structures continue. Functions of the hair. Erector pili muscle. Smooth muscle cells extend from the papillary dermis into the connective tissue sheaths that surround each hair. When stimulated, the muscle pulls on the follicle, forcing the hair to stand up. So if you get a chill, sometimes we can just make our hair stand on end, depending on what our mood is. So the erector pili muscle essentially grabs a hold of the hair follicle and causes the hair to become erect. Hair color. Pigment melanocytes produced at the pair at papillae. Genetically determined hormonal, environmental factors also influence hair color. White hair is a result from the lack of pigment and the presence of air bubbles within the hair shaft, and this comes with age. Clinical note, the hair and disease. You can note diseases from people's hair growth, distribution. It can also aid in the diagnostic process. Chemotherapy, which pretty much stops cellular division. But the nasty thing about chemo is whenever it's utilized, it does not, it pretty much kills every cell. So that whenever you give somebody chemo, it kind of isolates it sometimes, but however, in the same breath, it pretty much makes the patient very sick as well. The hair color is controlled by androgens, masculine hormones. Excessive hair growth could equal tumors, polycystic ovarian disease, hyperplasia of the adrenal glands, a lot of things that can cause excessive hair growth. Clinical note, and this is hair loss. You lose about 50 hairs a day normally. 100 hairs a day indicate a net hair loss. And then we can actually see some male pattern baldness. And the drug that is utilized for this is called Rogaine. So, clinical hair loss. 1.36, which is sebaceous glands. Sebaceous glands, oil glands, are holocron glands that discharge an oily lipid secretion into hair follicles. And then sebum lubricates the hair and skin and inhibits the growth of bacteria. So sebum is kind of a part of the immune system in that it inhibits the bacteria from growing on the surface of our skin, which is kind of a good thing. Sebaceous gland here, which is going to secrete stuff out. Bottom, if we'll notice that this has got ample blood supply to it. Next slide. Take a look over the sebaceous gland, figure 5.12. Sweat glands. We have apocrine sweat glands. Sweat glands that secrete their products into the hair follicles, in the armpits, around the nipples, and in the groin. And then we have merocrine sweat glands. Coiled tubular glands that discharge their secretions directly onto the surface of the skin. And these are the different types of sweat glands. This is a merocrine, and this is an apocrine. Another merocrine sweat gland. Nails. Nail body is pretty much the visible dense mass of dead keratinized cells, and this is whenever we look at our nails, that's what our nails are. Nail bed, under the nail surface. Nail root, proximal end, and the nail root is actually not visible, or you can't see it. You have a cuticle, which is actually stratum corneum. Fold extends over the exposed nail nearest the root, and the cuticle can actually come out onto the nail itself. And you have lunella, pale crescent area observed near the cuticle. And this is lunella, nail body. So everyone can see this. Epidermis, dermis, bone of the fingertip. So keratinized cells in the actual nail part, or what we would think is the nail, made out of essentially the lunella. And nail growth, or the site of growth, is way back here by our joint, almost. Alright, and that right there concludes part 1 of the integument, which is chapter 5. If you have any questions, please feel free to contact me, Roy Smith, at 405-219-7613, or you can shoot me an email at smith@imsa.net. Thank you.